right. Dr. Jamin Bled is a native of rural Northeast Texas. He's a local guy here. He attended Kansas City University of Medicine and Biosciences, where he received his Doctor of Osteopathic Medicine. After completing medical school, he returned to Texas for his residency at the University of Texas Health Science Center at San Antonio, and then and completed his fellowship with child and adolescent psychiatry at the University of Texas Southwestern Medical Center at Dallas, where he was the chief fellow. Dr. Blood is currently board certified with the American Board of Psychiatry and Neurology in Psychiatry, and he joined UT Health Science Center in Tyler in 2020 to be an assistant professor in medicine in our Department of Psychiatry and Behavioral Medicine. Dr. Blood is a team member for both the Child Psychiatry Access Network and our TCHAT program, which provides counseling in the schools with therapists. And so, Dr. Blood, we're excited to have you present today, and I'm going to turn this over to you.
Hey, good morning, everybody. Thanks, Laura. All right, so today's presentation is going to be on the distinction between oppositional defiant disorder and disruptive mood dysregulation disorder. It's so much easier just to say ODD and DMDD. When I first was learning, I could never remember what DMD even stood for, because I always got the words mixed up. So here we go. So what if I told you it's either one or the other? I always have to throw in a matrix picture there. All right, so here's our learning objectives. We're going to learn the criteria and common presentation for both ODD and DMDD. We're going to differentiate between the two disorders and then talk about some treatments for both of those as well. All right, so we're going to start with the oppositional defiant disorder. All right, here's the DSM-5 diagnostic criteria. And so it's a pattern of angry, irritable mood, argumentative, defiant behavior, or vindictiveness. This has to occur for at least 6 months, and they have to have at least 4 symptoms, the 4 of the following symptoms, and it has to occur to an individual who is not a sibling. So there's a couple categories. One is the angry, irritable mood. They have to either, they often lose their temper, they're easily touchy or easily annoyed, and is often angry and resentful. Under the argumentative and defiant behavior, they often argue with authority figures or children or adolescents or with adults. They often actively defy or refuse to comply with requests from authority figures or with rules, often deliberately annoy others or often to blame others for his or her mistakes or misbehaviors. And so you have to have 4 of those. So this is not associated with a stressor, and it can't be due to a psychotic disorder, a substance abuse disorder, depressive disorder, or a bipolar disorder. And here's the kind of thing that distinguishes. Criteria cannot be met for disruptive mood dysregulation disorder. And we'll talk a little bit more about why later. And so it's categorized into mild, moderate, and severe. So here's the basics. So it's a persistent pattern of defiant, disobedient, antagonistic behavior towards adults. So that's kind of the overview of it. There's not really any outright aggressive acts. There's not really any antisocial behaviors. It's a very common disorder. We do find that disruptive behaviors problems are usually associated with increased costs to like the society. You know, there's and to the family, time off of work, parents having to go to the school or things like that nature. And so there's also the thing that I find most interesting is they do have a poor adjustment outcomes later in life. They do tend to have more mood disorders later in life if they do have a persistent pattern of this behavior. So that's epidemiology, or the next is the epidemiology. So the prevalence is 2 to 10%, boys greater than girls. The symptoms do tend to decline after age 10 to 12. It's rarely diagnosed in older children. estimates do tend to vary across the country. The majority do not go on to develop conduct disorder, and there is a high rate of comorbidities, as this next slide will kind of show what's going on here. So you kind of see how they're kind of all interconnected, I guess is the best way to show the relationship. There's a very high comorbidity of ADHD, anxiety. Few go on to have conduct disorder, and then you kind of see how their lingering effects can kind of lead to anxiety, depression, and psychosocial impairments later in life. And it is a study back in 2019 by Copeland found that they consistently have been found to predict later depression in life. That's what I was referring to earlier. And it's usually young adult depression that when they'll start seeing it in young adulthood, but not conduct disorder. So here's the differential diagnosis, which you kind of need to keep on the spectrum on your radar is ADHD, of course. We already kind of talked about that. Autism, they may just not be able to understand the social aspects and social norms of rule following, who is the authority figure. Depression, they may just be in a depressive episode and they just may not care anymore about following rules or anything like that. Anxiety disorders, they just may be so distracted or preoccupied by their anxiety disorder that they seem rigid and not wanting to follow the rules or things like that. Phobias, and then obsessive compulsive disorder. So those are some of the common differential diagnoses that you need to be aware of. So assessment. So you really do need to be gathering information from multiple sources. You know, of course, parents, teachers is a good thing if there's after school care, that would be a great source. Grandparents can be a good source. So like I said, this is typically to multiple authority figures. So it's not going to be, it can just be the parents, but it's often bigger than that. It's often they have problems at school, they'll have problems after school care, or if they do any extracurricular activities, they may have problems with that. So that it's kind of really important to make sure that we get enough data. And like I said, we do need to run through a differential diagnosis to make sure that it's not something else. So like I said, you need to consider family members, school, neighborhood. And then another thing to watch out for is bullying and peer deviance. So bullying can really have a major impact on a child's life, especially now when bullying isn't just limited to the classroom. Kids are now being bullied online through social media, through text messaging. So bullying has kind of grown to a larger scale since I was a child. Assess for learning difficulties. Make sure that is there poor grades leading to this kind of defiant behavior? Is the poor grades from these learning difficulties? Do they have a reading disorder, a math disorder, things like that? That you can have the parents request testing done from the school if this is really something you might think it is. There are really no measures or tools or screeners for oppositional defiant disorder. There's really only one that I could think about that it's not even for oppositional defiant disorder. It's just part of a subscale in the child behavior checklist, and that's a long, lengthy thing that you will not be doing in your office. So, it could be diagnosed if you send them off for testing, but it's not something you're going to do there in your office. So it's really just talking to the families, trying to get extra information and trying to figure out, is there stressors? Are there not stressors? Is there what's going on? So that's kind of the big way to kind of figure out what's going on is really through your clinical interview. So the treatment for oppositional defiant disorder. So first, identify and treat comorbidities. If they have ADHD, really make sure that they're on adequate treatment for ADHD. Address the modifiable risk factors that you can with parenting style, things like that. Parenting management training, this is probably the biggest bang for your buck. There's skills management, there's PCIT, which is parent-child interaction therapy, is a really good treatment for behavioral problems, helping the parents to know how to address the behaviors in a non-authoritative or punishing way. And so that's kind of one of the best things for behavioral problems, which ODD kind of fits into that classification. There's alternative approaches. Maybe they need some type of intensive therapy program or something like that. School-based interventions. Make sure that they may need a 504. You typically will not get an IEP, individualized education plan for optional defined disorder, so most likely just a 504. They potentially need individual therapy so they can work on some anger management. Rarely is medication really going to be helpful in treating ODD. It really is more of a therapy type treatment, which takes me to my next slide. So here's the therapy option parent training. We already kind of talked about some of this. So parent training, just mental health professionals that are experienced in treating ODD can help develop skills that are positive, less frustrating for the parent and the child. A lot of times it's a parent and the child just working on these skills together with that professional there kind of teaching them. Parent-child interaction therapy is a little bit different. It's like the therapist is not in the room, but they're watching, listening, and a lot of times they'll have like a little microphone and a speaker that they can talk to the parents, like a little microphone or headset, and they can talk to parents through things without actually being there in the room. So it's more the parent and the child one-on-one or two-on-one if both parents can join. And those are both really good for younger children with significant behavioral problems. Say the child is a little bit older, they may do better from, oops, switch sides on accident. They may do better from individual and family therapy if it's a real big conflict in the family, you know, in their children, or if the child is more like an adolescent, then they can actually process through more of their feelings and can have more self-regulation. You know, individual and family therapy may be a better option for them. And then individualized cognitive behavioral therapy for, like I said, if this is more of an older child or adolescent. If they're young, they just may need social skills training. You know, it would help benefit them to be more flexible, learn how to interact more positively and effectively with peers. So those are kind of the treatment options for as far as therapy goes for oppositional defiant disorder. So these, like I said, there are some medications, but we don't really do, if they have just oppositional defiant disorder alone, we don't really use medications. Like I said, if they have ADHD, stimulants are still the #1 treatment. Rarely we use, especially if someone who was hospitalized, we potentially could use Depakote, which is sodium valproate, potentially a second-generation antipsychotic like risperidone or Abilify. SSRIs really don't show any effect or haven't found any evidence that they are better than the other treatments. Lithium, which is a mood stabilizer, or other anti-manic agents, haven't really found any evidence either for medication treatment of oppositional defiant disorder. So really it's back to parent training therapy options. All right, so these are the goals. So we want parenting skills, problem solving, conflict resolution, and proper communication from the parents. And for the child, it's going to be proper communication, anger management skills, and problem solving skills. And so the family could potentially need to get this through the family counseling and support, and then also make sure they're getting classroom involvement as well. Make sure that they have like that 504. Potentially the school when the school counselor can do things for social skills sessions and things like that. So those are kind of the treatment goals and for specific setting or persons. All right, so now let's move on to disruptive mood dysregulation disorder. And so they have, these are temporary outbursts with chronic irritability. When this first came out, when the DSM-5 came out, this was rather controversial disorder because a lot of people were labeling pediatric bipolar disorder and that's what this was to address. And then we'll kind of talk about DMD versus ADHD versus ODD versus bipolar disorder. That's kind of where we're going to go with this. So here's the diagnostic criteria from the DSM-5. So it's severe recurrent temporary outbursts manifested verbally or behaviorally with physical aggression towards people or property that is grossly out of proportion in intensity or duration to the situation or provocation. The temporary outbursts are consistent with developmental level. Temporary outbursts occurs on average of 3 times more per week. The mood between the temporary outbursts is persistently irritable or angry most of the day, nearly every day, and is observed by others, parents, teachers, family members, potentially you in your office. So A through D has to be present for at least 12 months, and the individual has not had a period of 3+ months without these symptoms. And then criteria A and D, at least 2 of the 3 settings, home, school, and with peers, are severe enough at least on one of these. So that's kind of the diagnostic criteria for DMDD. And diagnosis should not be made for the first time before age 6 and not after 18. So those are kind of specific age criteria for DMDD. And it has to be onset before age 10 for criteria A through E. And once again, there's never a distinct period lasting one or more days or full symptoms criteria met of having a manic or hypomanic episode. And so these behaviors do not exclusively occur during an episode of major depressive disorder and not better explained by another mental disorder. All right, so that's the DSM-5 criteria. I do want to read this note down here that they put in here because I feel like this is kind of important. It says the diagnosis cannot coexist with opposites of divine disorder, intermittent explosive disorder, or bipolar disorder, though it can coexist with others including major depressive disorder, ADHD, conduct disorder, or substance use disorders. Individuals whose symptoms meet criteria for both disruptive mood dysregulation disorder and oppositional defiant disorder should only be given the diagnosis of disruptive mood dysregulation disorder. So basically, when the creators of the DSM-5 came out with DMDD, it supersedes ODD. They cannot have both. If they meet criteria for DMDD, then that's what they have, not ODD, or both. All right, so here's its courses and outcomes. So childhood DMD diagnosis, it's kind of in the category of a depressive disorder. There's disruptive behaviors, there's poor peer relationships, there can be peer exclusion and victimization, relational aggression, and that's kind of more in the childhood setting. In the adolescent, it's more serious illness. They can be getting into other risky behaviors, and the police might be starting to get called. There might be property damage starting to get in. So it's really something that we want to focus on when they're younger instead of when they're older. The differential diagnosis is, so irritability and temporary outbursts are common to multiple diagnoses. So how do we really distinguish it between ADHD, oppositional defiant disorder, conduct, and bipolar? We do know that back in the late 90s, early 2000s, is that there was an overdiagnosis of bipolar disorder. And so that's really what led the developers in the DSM-5 to distinguish and come up with this diagnosis. Bipolar it doubled in adults and increased 40 times in people under 20. So they really wanted to make sure that people who are getting bipolar disorder were getting the proper diagnosis, because that can lead to treatments that were failing, use of medications that were not appropriate, over medicating, things like that. So that's really why they came out with this. Looks like I accidentally doubled up on slides and kind of have the same thing on both of those slides. I apologize. So here I wanted to show a kind of a graph of how all these symptoms can overlap and how we need to be careful in diagnosing these things. So restlessness is very common, poor concentration is very common in all of these. And all of these diagnoses, increased motor activity, distractibility. Irritability is a little bit less common, but it is still rather common. So how do we differentiate between DMD and, let's say, bipolar? So I found this nice table. And here's the big thing, is this top one. So they both have irritability. DMDD is a chronic persistent pattern. Bipolar is definitely an episodic disorder. So that's kind of how they want to distinguish the two. Bipolar comes in episodes. DMDD is a chronic severe disorder, and that's why it takes 12 months of meeting this to make the diagnostic criteria. Typically, bipolar is not diagnosed until you're a young adult. DMDD is going to be a younger child and a younger adolescent onset. There's rarely any psychotic symptoms in DMDD, but can be present in bipolar. Common comorbidities: depression, ADHD. Granted, depression is part of bipolar, but there's typically not ADHD present. Prognosis: this is going to be a chronic thing. They're both are chronic, and this is going to include more time having these symptoms in between episodes, like if they were bipolar. Bipolar is episodic, so they should have remission during or between the episodes, and DMDD does not. So DMD is more temper outbursts, a moody child. In bipolar disorder, they have grandiosity, increased risking behavior, decreased need for sleep, all those things. So that's, how it's set apart from bipolar disorder. I explain these other kids who don't go on to meet full bipolar disorder later on in life, what were they when they were a kid? And this is how it's kind of evolved over time. So here's the overview of DMDD. I've kind of already said all this, it's just kind of rehashing it. It's a useful diagnosis for children with severe non-episodic irritability. Once again, that non-episodic irritability is likely related to a depressive dimension. It's different from bipolar. We've already talked about that. And its longitudinal course, family history, and neuropsychological performance. We can only diagnose pediatric bipolar disorder when there's discrete episodes of mania. Like I said, we've already talked about that. And there's limited evidence to guide some of these treatments that were previously done in the past. So what treatments are there? Psychoeducation is a big part of this. Younger children with emotional dysregulation are more sensitive to change in parenting styles. So that's one thing we really want to focus on. We want to collaborate with teachers once again. So this is sounding very familiar with the treatment of ODD, right? So we want strategies for dealing with crises when they're having these explosive tempers. We want to do parenting programs, which we've kind of already talked about. We want to identify stressors and triggers, what led to these emotional outbursts. We don't really have a lot of clinical trials on DMDD treatments. We do use some off-label options. If we do feel like there is some ADHD, we can try stimulants, antidepressants, all these different things. But those are the comorbidities. They're not specifically treating DMDD. And so once again, we need a rule about abuse and neglect. That's a big thing. So here's the therapy options for DMDD. So parent training, parent-child interaction therapy. Once again, these are very similar. Individual and family therapy, cognitive problem solving, and social training. I'm not going to go through those again because we already talked about them. But these are the main treatments. Once again, it's a therapy style treatment for this disorder and oppositional defiant disorder. And we have other trainings on these types of therapy models that we'll give in the future, or I think we've actually already given some in the past. So here is the kind of the key to distinguishing between the two. They both can have chronic irritability, but typically in oppositional defiant disorder, when they're in between defiant episodes, they are typically fine or as far as their mood is okay and is stable. They may not be the happiest kid in the world, but they're not going to be chronically irritable.
Dr. Blood, we lost your sound.
Huh? How long ago did you lose my sound? I don't know what happened.
Just on this slide.
Okay, well, I'll start over because I'm not sure. So this is a good table to kind of differentiate DMDD from ODD. So DMDD has these extreme outbursts with chronic irritability. It does show that ODD has chronic irritability, but it's more episodic. It's in the context of their temper tantrums, their defiant behaviors, and shouldn't really be in the middle of those two things. So they both are. ODD is more commonly comorbid with ADHD than it is with DMDD. ODD has typically more delinquent behaviors. Social impairment is probably relatively the same. But here's the other thing: is these have frequent temper outbursts, and these have those outbursts with authority figures and defiance with authority figures. And so while some of these symptoms overlap, the criteria for DMDD, the symptoms threshold is higher, and so it supersedes ODD. I've already said this, and so it's just really to avoid artificial comorbidity of the two disorders. And so, this actually have a line from the American Psychiatric Association to help us distinguish it, and I'll read that. It says ODD is an ongoing pattern of anger-guided disobedience, hostility-defiant behavior towards authority figures that goes beyond the bounds of normal childhood behavior. While some of its symptoms may overlap with the criteria for DMDD, the symptoms threshold for DMDD is higher since the condition is considered more severe. And to avoid artificial comorbidity of the two disorders, it is recommended that children who meet criteria for both ODD and DMDD should only be diagnosed with DMDD. So that comes straight from the APA, who are the makers of the DSM. So that's kind of the overview of distinguishing these two disorders. One is going to be a chronic mood disorder. The other one is going to be chronic irritability and more opposition or problems with authority figures, problems following rules, and such. So, it's when these parents are struggling, what do you do when they're in your office? If this has been going on for a long time and they're just having a hard time getting into therapy, what about some self-help? So I did want to throw some self-help options into here. So these are 3 books that I have read and recommend. I may have not read them 100% through because I can tell you I haven't. But The Explosive Child is a very well-known parenting book to help with anger outbursts, oppositional children, things like that. I just recently started reading this Peaceful Parent, Happy Kids. It's more about teaching the parent how to self-regulate so that when their child is over or dysregulating, that they can keep calm so that they're not escalating the situation to the same thing. Gentle discipline is almost along the same things, it just does it in a different way. So those are 3 books I personally know about, and you can get them off of Amazon. They're relatively inexpensive. Maybe buy them, keep a copy in your office so you can show the parents that, hey, these are recommended. These next 3 were not recommended by me, but by a different psychologist, so I trust them. I haven't looked at them personally. So these are Transforming the Difficult Child was one that was recommended to me. Love is Letting Go of Fear, and then Raising an Emotionally Intelligent Child. And now there are some workbooks too that I wanted to talk about that I personally have gone through. These are just kind of 3, and I actually kind of keep some of these around so I can talk to parents about. So Anger Management Workbook, it's got like 50 different activities in there. And like I said, it is a workbook, so they're working in the book. They're going to need the parent and the child sitting down together to work on these things. Sometimes it's the kid will doing them alone. Sometimes they'll do a parent, but a lot of times the parent just kind of needs to help guide them and teach them these things. There's a whole series on this. On this what to do when you're, and so one of them is an overcoming problems with anger, and it's those temper flares. There's a whole series of what to do when, and those are actually pretty good for younger children. They're animated. They're lots of good creative activities in there that they do to kind of help teach them these skills. So it's a home-based therapy program, basically. So I'm not going to say you can just do these, because sometimes you can and they'll be successful. Sometimes it may be too hard to get the child to sit down, so they may need actual, therapy sessions to be able to get these two accomplished. So these are at-home workbooks that you can recommend for the parent and the child to do together. So these are my sources: the DSM, Lewis Child Analysis and Psychiatry is kind of the main textbook for child psychiatry, and then the international textbook for child and adolescent mental health. That's kind of where I got all my information from. And then I'll open up to questions.
So Dr. Blood, we've had a couple of questions come through. Some of it was answered already with your later slides. As far as medication, the question was medication. There's really nothing medication-wise for the actual diagnosis of ODD and DMDD, but it's really about the behaviors and changing the behaviors. Would that be a correct statement?
Yes, ma'am. Yeah, therapy definitely is the main treatment option. Sometimes we do use medication, especially if there's significant aggression, or if there's comorbidities like ADHD, you want to use stimulants. If they have autism, we may use, there's 2 FDA-approved medications for aggression and autism. So, there are definitely options, and we can always talk about those options when you do call into CPAN.
Another question that was in the chat was, if parents refuse to take the child, let's say that they're very opposed to talk therapy or counseling or such like that, how do you have a conversation with a parent like that? And what do you say?
So if the parent is not wanting to take them to therapy, is that kind of the gist of the question, I think?
Yeah, they're just not involved and they don't want to do the therapy route. What other options do they have?
Here in Tyler and in East Texas are some limited intensive outpatient programs. None of them are based with UT, so I can't speak to how well they work. Sending patients there myself, I've had some limited success. Some of them not really much improvement. So there are some intensive outpatient programs that you can do. Really, if they're refusing to take them to therapy, that would kind of really limit what you could do for the child.
Okay. We've had a couple of hands go up. It looks like Wiley, we had your hand go up. Do you want to ask your question?
Yeah, I just had a quick question, Dr. Blood. When we do get calls, sometimes obviously doctors will call. I've had a couple of calls where doctors had really kids in the office that were just extremely disruptive. Do you have any advice as far as office visits, if this is like maybe the initial visit and it turns out to be later an ODD or a DMDD diagnosis? Some maybe anecdotal advice for doctors that have these kids in the clinic and they're very disruptive, just maybe how to handle that, or how to set up the office to where that's more manageable in the office? Yeah,
so it kind of a thing that is common amongst therapy styles, at least in the intensive outpatient program settings, is they'll do a point system, which in younger kids, parents commonly use a sticker chart. You want good behaviors. When they see that good behavior, they're reinforced with a sticker. For a little bit older kids, they can collect points, and the points equal up to like TV time and some certain rewards. But I think the gist of those programs is basically they have to earn what they want. You know, if the kid only wants to spend time on their iPad, or they only want to watch TV or play video games, then they have to earn those things. You know, they have to do the things appropriate to their age to get those, and then they have to be limited in the amount of time. They can't be spending time on those all day, because that does tend to exacerbate those symptoms. Specifically in my youngest child, you know, on weekends, if he seems to be more irritable when we try to get him off of devices when he has more free time, than opposed to during the weekday when we really limit those kind of things. So really, you know, kind of hone in on scheduling, having the parents have a good schedule, limit electronics time, and then have them earn the things that they want, the TV time, the electronics time, stuff like that.
And another question, what is the benefit of distinguishing between these two diagnoses?
The benefit is, you know, when they originally came with it, like I said, they really wanted to overcome the overdiagnosis of pediatric bipolar disorder, because they really weren't, there was nothing to kind of be in that in-between, that gray zone of they have these kind of manic looking episodes, but they're always like that, and they're always angry, they're already irritability. So DMDD really needed to be separated out from bipolar disorder. As far as ODD, much of them do overlap. It's really that in-between time of where is their mood in between the outbursts. A lot of times ODD, the outburst is going to be in the context of not wanting to do something, not wanting to follow a rule, getting off of a screen time or something like that. And then when they're in between these temper outbursts, then they're going to be relatively fine. DMDD, there is just that chronic irritability, even though the treatment's relatively same. So the benefit isn't really from distinguishing between ODD and DMDD because they are so similar, and DMDD is going to supersede ODD. It's really that pediatric bipolar disorder that we want to stop getting overdiagnosed, because a lot of kids were being put on second generation antipsychotics, mood stabilizers, and then they really weren't getting improvement in their lifetime because the treatment really wasn't the appropriate treatment.
Thank you. Another question, as social determinants of health like poverty and dysfunctional family processes affect those disorders significantly, are there any resources locally in East Texas to assist these families that will complement the efforts of the medical provider? That is a one-stop for parents as a resource.
Oh gosh, that's
the $64,000 question, isn't it?
Yeah, if there was, you know, it's really working, you know, make sure that the PCP is on board, you know, with the parents, making sure they understand what the treatment options are and what is kind of the most important steps to take, making sure that the school is on board, because like I said, these are typically going to be having problems at school too, so they really need to make sure the school is involved, making sure that they're on a 504 at least, maybe they need an IP, maybe they need testing, so really make sure the school gets involved. And you know, if patterns continue, you know, there are some good programs through our local mental health authority that can be more inclusive and be helpful with the community involvement. I wouldn't say I know all about those resources because I've never worked for a local mental health authority, but their websites can kind of give some of the information, or you can just call them directly and find out. And maybe some of our therapists on here might know a little bit more about that as well. So if any of y'all want to chime in to help answer this question, please do.
Yeah, I'll open that up. I know we have CPAN and TChat therapists on here. If you're familiar with a resource that could answer this question, that would be great. If not, if that provider would give us a call, we could certainly do some research on that for you. All right, I'll take silence as we don't have anything without doing some research.
There's
Take
another.
a look at questions.
Yeah, there's
Yeah,
another one in the
another-
chat. Are there any benefits for getting the child involved in sports, academic, music, art, etc., and getting them in other activities? Would you recommend addressing behavior first in therapy, or would you do is concurrently both therapy? And 100%, yeah, I do think that a sedentary child who sits in front of the TV or electronic device, a tablet, a gaming device, they're going to have a hard time regulating their own mood and their behaviors because they're kind of letting that device do it for them. And so we all need physical activity. If a child only activity is I don't even know how long recess is. It's not that long anymore. My kids are always complaining how it's not long enough. And then in junior high, I have a 6th grader in PE. They're on block schedule, so it's only every other day that they're even getting PE, and sometimes they just don't do a whole lot in PE. And so physical activity definitely is a recommendation to make sure that all kids are physically active. I know the NFL, had that program to 60 minutes of activity, so there's lots of other programs like it, but it is highly recommended that kids are physically active, getting their body, their heart rate elevated, using their muscles. And actually that in the adult community, there is evidence to suggest that exercise and weight training alone can be a treatment for anxiety and depression.
Thank you, Dr. Blood. We've talked about how the younger these children can be diagnosed, better off those children are. So what's the future for these kiddos that have DMDD?
So
with that chronic.
Yeah. So it should be, treated more of a depressive symptom, and, therapy as they get older may be more in the line of cognitive behavioral therapy, individual therapy, to where they're learning, more about how to change their thoughts, which then changes their behaviors. And I did have them on my slides, the oppositional defiant disorder, it typically does get better after age 10. So a lot of ODD kids kind of just fizzle out as they get older. A lot more peer pressure to not have a temper tantrum in junior high. I know that's kind of a big thing. They're not going to be crying, kicking, screaming on the ground in junior high because they don't want to be made fun of. So peer pressure is kind of a good thing in that sense.
Any other questions from the group today?
And there's a good comment that Tina made in the thing. It says teachers should not be using taking away recess as part of a punishment. I 100% agree with that statement.
As a provider in a clinic setting, what is your number one recommendation? You've provided a lot of great information about the two diagnoses. If there's one takeaway, what's that one takeaway that you would like that PCP to have?
When the parents are coming to them in distress from these things, or they're coming to me in my clinical setting, I do recommend these workbooks and these parent books because they can get those right away and get working on the issue. It may take some time to get into therapy. It may take time to kind of get them set up with an IEP at school or a 504. So those things can take a while. So really understanding what they can do at home, those parenting skills. You may not have the time to talk about the point systems or sticker charts But you can mention those and they can go look those up online, because there's a lot of free resources out there for looking up those things.
I did want to let you know that Wiley did paste information about the Mentoring Alliance and did respond to the question by Dr. Pai that was located in our chat today. The Mentoring Alliance does have some supportive services. We do have the link in the chat as well for your continuing education. And then also you can see on your screen the QR code. If you would like continuing education credits, please do complete your evaluation, and those credits will be made available for you. And then I have to thank Wiley. He's adding a few more resources in the chat that can be helpful for providers that are located in Northeast Texas. Any other questions? When you complete your evaluation, if you would let us know about other topics you would like to have more information about, we are always open to new educational topics for us to present through the Child Psychiatry Access Network. And we are here and available Monday through Friday, 8 to 5, to provide you with consultation on child psychiatry, assistance with those cases that maybe are a little more challenging, or a new type of situation that you're dealing with one of your children and adolescents in your practice. Also assist you with referrals and resources that are those hard to find referrals and resources. And then at least twice a month, we're providing you with continuing education. So we are really glad that you joined us today. Dr. Blood, let's hang out on here in case we have any last minute questions that come on. Otherwise, for those of you who have joined us today, we appreciate your time, and we look forward to serving you through the Child Psychiatry Access Network.
Thank you, everybody.